Dr. Caleb Slater. I'm an expert orthopedic physical therapist with 17 years experience, and I treat differently than pretty much anybody else out there.
So we're going to start with McKenzie physical therapy, and I know this is a big part of your treatment methodology, but what is McKenzie physical therapy?
So Robin McKenzie was a pioneer. He was a physiotherapist in New Zealand in the 70s and 80s. His approach really started taking off, and what that was using repeated movements to primarily address spine issues such as a herniated disc.
And how does this differ from standard physical therapy?
Standard physical therapy is more about controlling the pain, strengthening the musculature around it. He was really one of the first to figure out that movement could actually reduce a disc bulge, a herniation.
So how did he come about this treatment approach?
It's actually a kind of a funny story. I don't know if it's true or not, but this is what I've heard over and over and over again, is a patient came in, and I think this was somewhere in the 50s, 60s. A patient came in to see him. He was busy. Patient's in extreme back pain, says, "Doc, you need to help." He's like, "I'm with somebody. If you just lay down here, I'll come back in a little bit and I'll help." It was kind of like a chase, lounge chair. So the patient laid down, but the patient laid down wrong. The patient lay down on their stomach. And when McKenzie came back, he looked and he was like, "Oh man." And he asked the patient to stand up. And when the patient stood up, the patient was like, "Doc, you're a genius." And his symptoms had gone away. He felt significantly better. And now, to Robin McKenzie's credit, he started to think, well, why did this work? Why did this patient who could barely walk and was in extreme back pain do something that most people would tell you not to do? Why did it work? And he pretty much figured out that the disc can move in and out. It can bulge a little bit here or there on one side or another, and if you figure out where that bulge is, and if you move the spine appropriately, you can actually move that material out of the way, that material that's getting in the way of the joint, putting pressure on the nerves, putting pressure on the ligaments, getting in the way of the joint moving, and you can restore normal motion. You can take away the pain.
So what about that discovery? Why was that seen as the wrong approach?
So at the time, treatment, and this even lasted much longer, the treatment was protection. We famously coined the Price or Rice method: protection, rest, ice, compression, elevation. And at the time, if you had back pain, you were in bed resting. So movement was discouraged. Movement was the enemy.
So that's what McKenzie physical therapy is, but how does that relate to your treatment methods?
So I became certified in McKenzie physical therapy about 7 years ago, and the reason that I became certified is it's kind of a bad reason. My wife and I were starting our own business, and McKenzie physical therapy, even though it's not well known, it's probably the best recognized among physicians. And I wanted to be able to sell our practice. And up until that point, I had had minimal interaction with the McKenzie method, other than other clinicians or schools that I had been to telling me that it doesn't work. So I went into it thinking, this is trash, this isn't gonna work. But I wanted that certification behind my name so that way it can open some doors or some conversations with some physicians so we could get referrals.
So having learned about McKenzie physical therapy, what did you find then?
So I was incredibly surprised on the very first course that I went to. It was a simpler, cleaner, linear way of diagnosing patients and of immediately applying treatment and seeing immediate results, something that I hadn't seen up until that point, and I had been a physical therapist for about 7 years. And I had 2 advanced degrees beyond my doctorate. I had my orthopedic clinical specialty degree, so my OCS, and I had a certified orthopedic manual certification through Maitland, which is a lot of joint mobilizations and stuff like that, a lot of stuff that like chiropractors would do. But those certifications put me as an expert level in my field. And I went to this course and I was pretty shocked on how much I not only liked it, but then was able to apply it and see immediate results. And up until this point, I had been told by pretty much any of my peers, any of my professors, that this was useless.
So what techniques did you implement from McKenzie?
At first, I tried to do everything by the book. I tried to do it exactly the way that they would do it, apply McKenzie's methodology exactly the way it was being taught. And although I did see a lot of improvement in my patients, and it really helped change my view of how I was treating the patient and what information I was giving them, I did see some limitations. It did fail in certain circumstances. It did not treat certain conditions or certain symptoms as well. And it had worked better than anything that I had found in my career thus far, but it was still at times letting me down.
So what did you change or do different with your new treatment approach?
After a while, after maybe about 3 years of really trying to do everything by the book, trying to go to the advanced courses for McKenzie, getting certified in it, trying to even teach it to other practitioners, trying to find other teachers of McKenzie and see if they had any different solutions. Or after about 3 years of doing that, I started doing some stuff on my own. I started troubleshooting it myself with some of the McKenzie philosophy as the foundation of what to do. Making some small changes over time really led me to just significant outcomes, significantly better outcomes than what I was already seeing. And one of the biggest changes that I made was McKenzie is very passive. They have the patients do the movements, but the movements are very minimal in muscle contraction. And what that does is that might help get you a little bit more mobility, but it won't keep you better. It won't get muscle contraction, blood flow, strength. It doesn't promote healing as quickly. And again, it might make you feel a little bit better and it might make you more mobile, but it's not going to make you stay better. And that's what you need muscle contraction for. So instead of doing the movement, let's say a press up, kind of like a cobra pose, that's a staple of McKenzie. And you're supposed to kind of turn your back off. So your muscles aren't doing it, it's just your arms. Your arms are making your lower back extend. Well, why not use the muscles to move you into that range? And now all of a sudden, not only have you restored that range, have you taken pressure off that disc, but you've also gained control and strength of your spine in that range.
So you kind of adapted a hybrid approach of McKenzie and other
A lot of, just like anybody else, a lot of my techniques that I've come up with, I've stood on the shoulders of the people that came before me. Like I said, I became certified in Maitland. I went through a lot of Syriacs and McGill courses. I did my OCS, and then obviously McKenzie, and I kind of put all of that teaching together, but then at a certain point you have to see what's working clinically and what's not, and you have to make adjustments. And kept making adjustments slowly over time, and those adjustments led to, in my opinion, a pretty significant difference. At least a difference in the outcome for my patients.
Did you discover any other limitations with the McKenzie method?
There's a few limitations with McKenzie that I've seen, and one of them being that it's too passive, so they're not getting muscle contraction. Another one being that McKenzie evaluates you in a few ways that I would do differently. And one of them is they say the most distal relevant symptom is the one that's the most important. I actually disagree with that. I think it's the most proximal relevant symptom, the one that is highest up. And the reason is that I have seen an affected area above affect the area below. We know this. So your body pretty much works brain, brainstem, spinal cord, spinal nerves, down and out. And an area above can affect an area below. So let's say you had hip pain, knee pain, shin pain, and foot pain. McKenzie and their teachings would say that the foot, the most distal, the furthest away, that is the most relevant symptom. That's the one that you want to treat. So they're starting to treat the area of the spine that correlates to the foot. And this would be your L4, L5, S1, your lower lumbar vertebrae. But that does nothing to explain your hip. So why is your hip? And your hip is innervated by higher up in your spine, your T12, L1, L2 area. So this is your upper lumbar spine. And I've seen it clinically that treating the higher up area will have an effect on the lower down, but typically not the reverse. So instead of going after the most distal relevant symptom and correlating that to the area of the spine, I correlated the highest one that I could find. And that basically fixed not just the hip pain, but then also typically fixed the lower leg pain. And at the very least set me up for success to fix the lower leg pain when I needed to go further down, but often I didn't have to. You could kind of picture this like a highway where you have traffic going through, and let's say you have a 4-lane highway. And again, your highway is your nervous system. So brain, brainstem, spinal cord, spinal nerves, down and out. And traffic's going. And let's say you have a car accident at exit 1. That car accident is taking up a lane and traffic's going to go through, but it's going to go through a little bit slower. But let's say you have another car accident at exit 2. Now that other accident that's already had some slow moving traffic to it has much more of an impact. There's something called double crush phenomenon where they found in, I think, the 70s, they were doing surgery for carpal tunnel. Carpal tunnel is an irritation of the median nerve that comes out of your neck, travels down your arm, passes through the carpal tunnel, and gets compressed. They were doing surgery. During the surgery, they viewed carpal tunnel compression, the collapse of the tunnel. They did the reconstruction to take pressure off the nerve. They woke the patient back up, and the patient was no better. And they were like, why? We saw the compression, we took the compression off, why isn't the patient better? And they realized that there was additional compression higher up. And again, that higher up compression on that same nerve can affect lower down, but not the reverse. Often what I found is that if you figure out what the highest level of compression is and you fix that, you see all the changes below. And we know this to be the case too with spinal cord injuries as well. If you have central cord compression, so central stenosis, compression on the spinal cord because of a disc issue or spondylolisthesis or whatever at your neck, you'll get symptoms into your lower extremities. You'll get gait ataxia, you'll get weakness, drop attacks. You'll have symptoms lower down because above affects lower and not the reverse.
So did you find any other limitations?
Yeah, so a few. And again, I want to give credit to Rob McKenzie. I think what he did and the system that came out is one of the better ones. But, and I am constantly confused on why it's not more widely adopted. But maybe some of these limitations, maybe some of these improvements that could be made are the reason it wasn't more widely adopted. Because it did work and it worked well, but it failed a little bit. And one of the big ones is they do a lot of lumbar extension, just a ton. They do a ton of press-ups, and if you wanted to oversimplify his approach, and it's press-ups. So it's extending your back and extending your back. And this might have changed over time as our body positioning changed. But what I have found is that basically the complete opposite is needed. Your lower back doesn't need to extend. It actually needs to flex. You need to restore flexion into your lower back, and that solves a lot of these issues. Solves a lot of the back pain, a lot of the hip, knee, foot, and ankle symptoms. And you want to do it loaded, which is another thing. So they will do lumbar flexion, but they'll do it unloaded. They'll basically do a stretch, like a happy baby stretch. And it's not enough force, and it doesn't get as much pressure through the upper lumbar spine. So what I've done is I basically do a modified version of a Jefferson curl where you grab a weight, typically start with somewhere around 20 pounds, and you slowly curl your spine, the complete opposite of what you would do in McKenzie, and you slowly curl your spine down, and you do that over and over and over again, and I found that to be so much more effective. Another limitation of McKenzie is that they don't do enough to the thoracic spine. So your thoracic spine, your upper back, it's basically the foundation of your neck. And from that thoracic spine area, you have a lot of innervations to your arms, and again, it's your neck foundation. So if I do anything to my neck to try to fix it, but my thoracic spine is stuck forward, I'm pretty much going to lose those gains. So McKenzie, they do some rotation to the thoracic spine, but that's typically not what's needed. Most of the time it's extension. So if you think about it, we sit in a chair all day long. We drive to work, we sleep, we read, we watch TV, we cook dinner. Everything is down in this position. Reversing that really solves a lot of these chronic positioning problems. In order to do that, you need to really use a lot of force. So McKenzie will have the patient do it themselves sitting, but it's really hard to get that area because you'll compensate with your lumbar spine. So they'll have the clinician add some overpressure with their hands, but it's really hard. I'm 200 pounds, I'm 6 foot. Even me doing that on a smaller female, that's 5'4", 120 pounds. That gets really tiring for me after 10 of them. So it's hard for me to do, and that patient can't take that home. That area of your spine is blocked by ribs and by your shoulder blades. So you need a lot of force in order to get there, and you need a fulcrum in order to really try to get that spot. So I went to the foam roller, and I started doing the foam roller exercise for myself, for my patients, and I saw a lot of gains there. But that's also not enough because you still will arch your low back. So I started positioning your hips, knees really far to your chest to lock your lumbar spine. I started locking the cervical spine a little bit by putting the hands behind the neck. And now you're biasing the thoracic spine. So now you're getting a lot of movement through this area. But this is still passive. This is still just getting movement. And like I said at the beginning, that will make you feel better, that will help. But if you want to stay better, you need muscle contraction, strength, control in that range. So you need to add to that. And again, that's something that McKenzie just doesn't do.
Is there a diagnosis that McKenzie treats that typical physical therapy doesn't?
So McKenzie treats in a different way. They started with just the spine, and then they realized that in treating the spine, they were treating some peripheral issues. So that would be shoulder pain, elbow pain, wrist pain, hip pain, knee pain, foot pain. They realized that when they were treating the spine, those other symptoms were going away, and that made them realize that it was a nerve issue all along. And give McKenzie a lot of credit. They have studies out there that say arm pain is probably pretty much 50% neck pain, okay? Leg pain, somewhere around the same. But what they didn't do is they didn't take it a bit further. They knew that treating your spine could treat your knee pain because it was misdiagnosed. They found that out, but they didn't take it a little bit further. If they knew that the nerve innervates the knee, and that nerve irritation can cause all those same symptoms at the knee that get misdiagnosed as meniscus tears and degenerative joint disease and chondromalacia and stuff like that, if it can get misdiagnosed, orthopedically, it can also get misdiagnosed with some of the other more, we'll say, internal chronic conditions. So like breathing issues like asthma, heart rate issues, GI issues, pelvic floor issues, right? Your spine innervates all of these areas, sends that signal to these muscles and organs, and it helps them act properly. It helps them be normal. And if that signal isn't getting there, if that signal's delayed, these organs or muscles, they're not acting as optimally, and eventually you're going to see some problems. And those problems might be difficulty breathing, might be elevated heart rate, might be GI related issues, constipation, diarrhea, pain. It might be inability to contract your pelvic floor, bladder pain. And what we saw when we took this just a little bit further, we took the same thought process that McKenzie had, that if treating your neck can treat your elbow, why not treating the same areas of your spine that correlate to your organs can treat your organ pain? And it was kind of from that this really took off. So now I treat things that I never thought I would be treating. I have patients that come in for Crohn's or ulcerative colitis, or pelvic floor conditions like interstitial cystitis and bladder pain, pudendal neuralgia and stuff like that, stuff that it was diagnosed under this. And by the way, most of these diagnoses don't have an underlying cause, or at least not a true cause, not a true definitive test. A cluster of signs that sound like these conditions, but we're not quite sure what is the actual cause, where it's actually coming from, or why it's actually coming from. But if you apply this, in my opinion, very linear, logical evaluation, this logical, could be the nerve coming from the spine, nerve not getting there, see if it is, and if you address that and if you fix it and those symptoms improve, then you've just diagnosed you've not just diagnosed the underlying cause, but you've actually treated it.
So what does it look like for a patient who uses you versus a traditional physical therapist?
I've been at this 17 years, and over that time I've accumulated 4 advanced orthopedic certifications, my doctorate. I've opened a practice, grown it, multiple locations. My wife is an expert physical therapist who has certifications in geriatrics, multiple certifications in women's health, and McKenzie certification. I have lived this life, and I've had some of my own issues health-wise as well. Chronic shoulder pain that just wouldn't go away no matter who I saw and what I did. So I was looking for answers not just for my patients, but for also myself. And because of that, I kept trying to find something better, and I kept trying to improve on what I knew. And so now, what I see different from what I do, from what typical physical therapists do, is I've eliminated anything that I didn't think worked, that I didn't think helped, or it didn't help as much. And unfortunately, it's a lot. If you go to most physical therapists, they're going to have you warm up before you start. They're going to have you walk on a treadmill or do an arm bike or a recumbent bike, or they're going to put a hot pack on you. And all this stuff might feel good, but it doesn't do anything. They're going to do treatments to you that have the same effect. They're going to do massage, they're going to do stretching, they're going to do trigger point and Graston and ART, and they're going to do some contract relax and some stabilization exercises, and they're going to put some tape on you, or ultrasound or laser. They're going to do dry needling or acupuncture, and they have all these tools in their toolbox, right? But all these tools pretty much have the same effect. They make you feel good in the moment, but they do nothing to help you stay better. They might help you gain a little bit of range of motion, but they do nothing to help you be stronger in that range. So I went, and to be fair, I did all of this and more to myself and to my patients, and sometimes it would work, sometimes it wouldn't. Sometimes with a patient with the exact same symptoms, it helped this one but not this one. Sometimes it would help a patient get 50% better, but then it would plateau, it would fall off. And I just kept moving on from what wasn't working. And the methodology that I came to is just a real simple one. Figure out the symptoms. Why is the patient here? Map out those problems. If it's knee pain, how far can they squat? What pain do they have with it? How far can they bend or straighten their leg? How strong are they in certain positions? But then look to the correlating area of the spine, see if there's a problem, treat it, and see if those knee symptoms that they came in for changed. And the way to treat the spine isn't to do core neutral strengthening, isn't to do stretching, it's to do end range mobilizations with strong muscle contraction. And just by doing that simple approach, I've been able to see significant improvements more quickly across a whole host of diagnoses and symptoms, and improvements that last.
So McKenzie is known for having the patient do many of the movements. Do they ever do any hands-on techniques?
So they do, and here is maybe a very glaring flaw of McKenzie, is that their mobilizations, their hands-on techniques are poor. And I'm trying to be kind there. Maitland, Jeffrey Maitland, him and a lot of other clinicians like Syriacs and slipping my mind right now, but Mulligan, they came up with mobilizations, and they do such a better job at being more precise. And Maitland specifically, Maitland is very, very precise where they're pressing on, what they're pressing on. They're using the tips of their thumbs for the most part to press on an area, and they are getting so specific with the pressure they're using, the depth that they're at, the area that they're at. That was really helpful for me compared to McKenzie, where they just put the palms of their hands on a patient. They're kind of rocking back and forth. They're really not palpating anything. And so if you talk about treatment, like if you go to a chiropractor is going to do a lot of what I was talking about. They'll push on specific areas, they'll crack your back. And I do find that helpful to provide patients with immediate relief. And that's something that McKenzie doesn't do versus some other techniques like Maitland or chiropractor. You know, the clinician working on them to provide immediate relief. And a McKenzie trained person would say, well, the whole point is to put the onus on the patient, to give the patient the tools to make themselves feel better. And I completely agree with that. But two things. Number one is you can really expedite the process of the patient feeling better by first working on them, mobilizing an area that's stiff, stuck, being more direct at that mobilization than the patient can be with their global movements. You can be more specific. And if you do mobilize that area, loosen it up, now the patient can then mobilize that area themselves and maintain or improve on what you did. So you can get the patient there quicker. But the other thing, and the thing that really helped me, was that in my diagnosis, in my first visit, my evaluation, pressing on the individual levels of the spine was a significant tool at the beginning of this process on figuring out not just where was the pain coming from, but what other levels were involved in their symptoms. We all like to think of these conditions as isolated. I have an L4, L5 disc bulge, right? I have a herniation at C3, C4. Yeah, you have that, and that might be the main area, but there's areas above and below that have also been taking up too much force and too much of a certain range, and you don't realize that how much involvement is there. And you don't realize sometimes if a patient comes to you and their symptoms are just kind of all over the place and you're really not sure, or they're presenting with symptoms that are different than anybody else had come to you with before, and you don't have a clinical diagnostic cachet to pull from to categorize this patient. Well, if you just put the patient on their stomach and you pressed on the individual levels of their spine and you felt which ones are stiff and the patient told you which ones are painful, you can really get precise about what levels and how much those levels are involved. And now, based on where the patient has the problem, now you know how to treat it. And that's something that McKenzie just didn't do well.
Where do you see the future of physical therapy and its treatment methods going?
So I hope there's a lot of change, and I hope to be a large part of that change. Like I said, I'm not trying to insult anybody. I'm not trying to throw shade on my own profession, but if you see inefficiencies and you found something that you have seen work better than anything else that you've done, then it's kind of on you to say something. And a lot of the treatments that we offer right now, they just don't work, or they don't work that well. And there's a simpler, more direct, and in my mind, anatomically, physiologically logical approach to a lot of these symptoms and conditions. So that's why I wrote my first book. That's why I'm on TikTok and Instagram and trying to get this information out there. I'm coming up with treatment books that I'm trying to give my philosophy. My wife wants me to teach courses, and maybe that's in the future, but I hope that this type of approach, this type of philosophy becomes adopted, because not only is it more effective, it's simpler. I work a lot less with a patient. Most of the stuff that I'm doing is educating the patient on changing what they know, what they've been told, what they think their body is doing, and why the symptoms are there, and just showing them a different way to view their body, a different way to view their symptoms, a different way to view their rehab, and undoing a lot of the education that they've been given about insoles and back braces and TENS units and heat and ice and stuff like that, stuff that primarily is a Band-Aid. A lot of the treatments, not just in physical therapy, but in pain management. So medications that just numb you to your symptoms, do nothing to address the underlying cause or even explain it. Epidurals, cortisone injections, nerve ablations, all of these treatments just numb you to your symptoms. They do nothing to explain or treat the underlying cause, and we offer these to patients as a cure. And I see a more logical approach that, if applied sooner, would get a lot of people out of pain and quickly, and keep them from these unnecessary, ineffective procedures.